From the JAMA Network, this is JAMA Otolaryngology Head and Neck Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Otolaryngology Head and Neck Surgery.
Hi everyone, this is Paul Bryson. I'm your web editor for JAMA Otolaryngology, and I'd like to welcome today Dr. Mark Mims. He's an assistant professor of otolaryngology, head and neck surgery, and plastic surgery at the University of Oklahoma and OU Health. We're going to talk today about surgery-related considerations in the management of cannabis users. Dr. Mims, welcome to the podcast.
Thanks so much for having me. I'm very excited to be here.
You know, when I found out about your article, it's very topical, and across the United States, we hear more and more about various states legalizing cannabis or having cannabis-related products for health issues. I just wanted to have you on and talk a little bit more about it, and just start by telling us a little bit about your background and how this topic became of interest to you.
I'm a facial plastic surgeon and started practice about a little over 4 years ago. As I moved from training to my faculty job here in Oklahoma, I became acutely aware of a growing population of my patients who were using substances that I knew very little about. And those substances were cannabis and cannabis-related products. And my patients would say, hey, doc, I use medical marijuana or I use some edibles. Do I need to stop these for surgery or can I keep using them? And I really didn't have a good answer for those patients. And so I started to do a little bit of digging and realized that there really was a paucity of literature out there for our patients who use cannabis and how to manage these things in the perioperative setting. I was very fortunate in that one of our lead researchers here at the University of Oklahoma, Dr. Lourdes Cremado, she has been a force in evaluating tobacco use and e-cigarette use and was transitioning her work as well into cannabis use. We felt like this was a very appropriate and timely partnership to form to really try to answer some of these questions that our patients were asking us. Interestingly, Oklahoma is one of the top users per capita of cannabis through the country, and about 1 in 3 Oklahomans have tried cannabis at some point. Approximately 1 in 5 use it on a regular basis, and so these are patients that are coming into our clinics every day, and we're trying to figure out how to manage from a holistic standpoint, and this is something that you just can't ignore because there's so much that goes into it from a local and systemic effects of the use. We really kind of set out to try to figure out, okay, what do we know about it and how do we bring this information to our patients so that we can provide better care for them? And that was really the impetus for this project.
Yeah, it's very surprising. I wouldn't have guessed that amount of usage in the population. How did you design your review for this particular paper?
I really wanted to focus on the available evidence for clinical use. There is a lot out there from the basic science side and the translational side that is looking into mechanisms and looking into all these different effects of cannabis on various cell lines, which is obviously the backbone of any clinical research project. However, we really wanted to focus more on what can we do talking to physicians, telling them how to help manage their patients better? While certainly all the recommendations that we go through and talk about during the paper have their basis in basic science research, we really wanted to focus on the clinical aspect of it because that's really where physicians are going to be meeting with their patients and discussing. We did a deep dive into the literature and read through as many clinical articles, translational articles as possible. You know, I have some background in looking at cannabinoids for wound healing. That gave me a good basis for, okay, here's what the general state of the basic science is. Now let's see what's the general state of the clinical work and how do we marry these two in a way that is approachable for physicians that can provide then recommendations for their patients who are going through these perioperative settings.
Talk just briefly about the work in cannabinoids and wound healing. That'll segue nicely into some of the clinical translational stuff that you were hoping to share.
A lot of the work has been done on cannabinoids, which is a subset of cannabis-related products. Cannabis is a large umbrella term for any number of things and is often used interchangeably for words such as marijuana or CBD or anything like that. But really, cannabinoids are the chemical compounds of the cannabis plant that have some sort of medicinal benefit or effect. We are looking at cannabidiol, CBD, because it seems to have the best evidence for wound healing and a lot of that stems from its ability to modulate the early acute inflammatory phase. And going back to those basic science papers, a lot of them have demonstrated a decrease in those pro-inflammatory M1 macrophages that are coming through in that early wound healing process. By dampening down inflammation, it's speeding up the time to re-epithelialization, it's speeding up the time for those fibroblasts to get into a more organized system within the dermis. And so we're starting to see some potential clinical relevance for future studies. In fact, that's one of the clinical trials that's coming up soon for me. We just got FDA approval and IRB approval and grant funding for a study looking at CBD and scar healing, where we will be putting cannabidiol head-to-head with the gold standard of silicone and seeing in a split scar study manner which of these products is going to perform better, and does that modulation of the acute inflammatory phase that we see in basic science work, does that translate into clinical outcomes?
Yeah, congratulations on that. That's very exciting. And it's something that people might think of as recreation, but actually pulls it right into something that could help them in the short term with perhaps a complex surgery or something where you have concerns about wound healing.
Definitely. And I have to give credit to one of my patients who, every time that I saw her after doing a skin graft for a Mohs reconstruction, she would say, "Hey, look how good my skin graft looks. Look how good my skin graft looks." And I said, "Yeah, I think it looks fantastic." And she's like, "Well, the reason is because I put CBD on it every night." This is 3 months after the surgery. I'm like, "Really? I'm not sure I would have advised that, but thank you for sharing." And so that really got the wheels turning. Like, is there something to this? And again, with Oklahoma having a higher population, I've now picked up a couple of patients who, after the fact, tell me, "Hey, I've been using this and I think it really works." We're just going to see in a more robust fashion if what they're seeing subjectively can be determined objectively.
Let's take it back to the review paper here. And what were some of the findings, or even any sort of guidance that you now do or that you've learned or that you feel like is supported by your review?
I think there's a lot of things in the review that will be very relevant to providers who are trying to counsel patients on perioperative settings, because the effects of cannabis use, whether it be the marijuana, which is typically what we think of when we think of cannabis, but also the cannabidiols and the minor cannabinoids, can really have a big systemic effect on our patients. And so what we see is, first of all, a big change in lung physiology. And so we are seeing lung physiologies that are very reminiscent of our tobacco smokers, where we're having hyperreactive airways. We're having patients who, with chronic use, develop emphysema-like pictures on their x-rays and their PFTs. When we're talking to our patients now, especially with the inhalational use, I'm really trying to work with them for the time around your surgery. This is probably not a good idea, because as we have to intubate you and breathe for you, we're really going to be stimulating your airways. And if they're already hyperreactive, that could lead to problems down the road with getting off the ventilator after surgery and prolonged intubations. And so inhalational use in particular seems to be correlated with this hyperreactivity of the airways, which makes sense. And the other thing that we're finding is that even though the cannabis products tend to have fewer other compounds than tobacco smoke may have, the inhalational temperatures at which we're using the cannabis products are much higher. And so that higher inhalational temperature can actually cause more damage to that fine lining of the airways and cause more hyperreactivity. And so it's definitely something, you have patients that are using recreational cannabis or marijuana from an inhalational standpoint, you really want to be aware of their short-term use as far as when was the last time you're using it, because that may play into some of our effects with anesthesia, as well as their chronic use from an emphysema picture standpoint. That's one aspect that anesthesia is going to be worried about. Another aspect is just how the medicines that they use for anesthesia really interact with cannabis. And so cannabis is mainly metabolized through the liver, through the CYP enzyme pathway. And so where any medication that is metabolized through that same process is going to be affected. And so a lot of our anesthetics are metabolized through the liver. And so patients who are actively using cannabis-related products, be them inhalational, edible, transdermal, anything that's getting into the bloodstream and needing to be metabolized, will cause some issues with anesthesia, from a depth of anesthesia, from a ability to wake up afterwards. So we're seeing prolonged wake-up periods after surgeries because of that heavy cannabis use. And so they're having a lower metabolism of those anesthetic agents, and so they're hanging around for longer and really giving some increased durations for wake-up periods.
We always ask about tobacco use and other things, and you make a pretty solid argument to have that really be part of the pre-op questionnaire. It may be something that patients may not always want to share.
Absolutely. And it is sometimes hard to tease that out of patients because they think that you're going to try to get them in trouble with somebody or you're going to look at them differently. And it is something that you have to kind of be upfront with them and say, look, I'm just like any other drug or medicine. I'm just trying to make sure that I have the complete picture so that when we take you to surgery, which is no small feat, no matter what the surgery is, we can take care of you in the safest way possible. One other thing that we often get asked about is patients say, I want to use my cannabis because I've heard it's really good for nausea and really good for vomiting. And so I get real sick after surgeries. And so I really want to make sure that I can stay on it so that I can use it. And it's true that FDA has approval for using cannabinoid products for nausea and vomiting, but specifically in the setting of chemotherapy-related nausea and vomiting. And I want to make a distinct difference between chemotherapy-related nausea and vomiting as well as postoperative nausea and vomiting because they're very different mechanisms. And in fact, a lot of the research shows that cannabis use can actually increase postoperative nausea and vomiting because it's delaying the gastric emptying, it's providing some central nervous system effects. And so these patients often experience a hyperemesis syndrome as opposed to the relief that they were expecting. And so you always want to make sure if patients are using that as a rationale for continuing cannabis products to say, listen, there's actually good data out there to showing that it's actually going to do the opposite. And so we may want to, if that's the reason that you're planning on using it postoperatively, we may want to reconsider that option.
I wonder how many folks in our surgical community are aware of this, particularly in states where recreational use may become legal. I'm talking with you today from Cleveland, Ohio, and our state will have recreational use here just this month. So it's very topical. What other sort of domains did you have information to report on?
Another big topic is pain after surgery. A lot of patients think that their cannabis or their edibles or whatever formulation they use helps them with pain after surgery. And they say, that's the only thing. I don't take opioids. I don't take over-the-counters. I just use my cannabis products, and that's what helps me. And there is some evidence for that. People who are low users or infrequent users, then cannabis may have some role in pain relief after surgery and may, in fact, be better than some opioid-type medications. However, the tricky thing is it seems that patients who are chronic high users of cannabis actually experience worse pain with cannabis use after surgery. And so, again, when we're talking to our patients who are using cannabis, one of the critical things that we're trying to figure out is how much are you taking and how much is too much? And that is really a question that science does not have an answer for. There are so many factors that go into it, from body habitus, gender, age, other metabolic factors, that we really can't give a solid definition of how much is too much as far as a discrete number. A lot of my patients ask, well, can I take 50 milligrams of edibles, or can I do one joint in the morning, or how much can I use? Really, what I tell them and what the literature seems to tease out is that it may not be quite as much how much you take in an individual setting or day, but how frequently you are using it. Our patients who use cannabis more frequently than monthly may fall into that high user category, weekly or daily use. For those patients who are using it monthly or less, that probably falls into a low category of use. And so we want to be sure that we tease that out, because just as any other medication, any other substance, you don't want to have somebody that's using something every single day and then say, okay, well, you can't use it for the next 4 weeks while you're healing from surgery, because that can tip them into a withdrawal syndrome, again, just like any other substance. And so you really have to be careful when you're managing these patients, how often are they using it and what kind of recovery are they looking at, because it may be better just to tell them, look, you use this every day, multiple times a day. We just need to keep you on it, because if you were to come off of it, that may actually impair your ability to recover from surgery afterwards. But we need to monitor those things and make sure that it all is going okay with the treatment plan that is proposed.
I think about just our specialty and head and neck reconstructive work that you do. I'm sure there's questions with our colleagues that maybe do abdominal surgery or neurosurgery or things like that, right? That is still pending and needs to be further determined.
I think all the things that we've talked about today, from the anesthetic effects and the pain and the nausea and the vomiting, are all important. But I think really what the review boils down to is that you need to have an open conversation with the patient And in the setting of elective surgery, you have time to figure things out. One thing that we haven't talked about yet is that there has been shown repeatedly to be a tachycardic effect in the acute use phase from cannabinoids and cannabis-related products. That tachycardia can actually lead to a 5-time increased risk of myocardial infarction on induction in surgery in that first hour after use. That risk seems to taper pretty rapidly after that first hour, but if you've got any kind of elective surgery, it's probably worthwhile not jumping right into that if somebody has just used marijuana-related products. Now, if it's an emergency, then obviously you have to weigh the risks and benefits. But certainly if you have somebody that you're a little bit concerned from a cardiac standpoint, or you know that they just had an acute use within an hour, it's probably worth pushing those patients out and saying, hey, let's wait for a little bit. Let's let this acute phase taper off so we don't put ourselves in an unnecessary risk.
I really appreciate your time today. I really appreciate you and your team's efforts to put this review out. And I anticipate we're going to be seeing more from you and your group. And, there's a broad reach to this information, right? I think the hope is not just in our field, but anybody else who might be interested in this, who does surgery or procedures, even elective awake procedures. There's probably some important considerations, even in our non-anesthetized setting in the office.
It doesn't just relate to anesthesia and those types of procedures that are done in the operating room, like you said. This is something that these patients are using it regardless. And so if you're doing in-office procedures, I do several Mohs reconstructions, lots of lipoma removals, cyst removals in the office. And so all of these things play into that exact same thing. You're putting stress on a patient's body regardless of whether or not they have anesthesia on board. And so whether or not they've used cannabis and how often they've used it and when was the last time they used it, all of these are important considerations. And so I think as the next 4 or 5 years come out, we're going to see a wealth of knowledge come out and seeing how all these things affect, because as you mentioned, more and more states are moving towards this legalized recreational marijuana use, even if they don't have medical marijuana use already. And so we're going to see a lot more of these effects that we say, something happened to this patient and I just can't explain why it happened. And it probably was related to their cannabis. And so we'll find out more here in the next 4, 5, 10 years. And so definitely stay tuned, and we'll be keeping in touch about all of those recent updates.
Well, Dr. Mims, really appreciate you joining the podcast. And I look forward to our listeners and readership having the opportunity to go more in depth with your review.
Thank you so much for having me. It's been a lot of fun.
This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.